Hi, I'm Adam Borelski and I'm a hospitalist. Today we're going to talk about DVT prophylaxis. This is for the adult inpatient medical patient. So this is not for surgical patients, and we'll talk generally about how we approach giving DVT prophylaxis and deciding on DVT prophylaxis for these patients. So the first thing I want to do is take you back a little bit to medical school. Jess, do you remember Virchows Triad?
No.
All right. So these are the three things that contribute to hypercoagulability or clot formation. So the first one is venous stasis. The second one is hypercoagulable state. Forgive my spelling. And then the third one is endothelial damage. And when these three things are present, it contributes to clot formation. So I want you to keep this in the back of your mind as we're going through this. So the first thing I usually think about is who are the folks that are at high risk for a blood clot when they're in the hospital. And to think about that in general categories, you think as age increases and as some of these risk factors increase, a lot of times it goes along with comorbidities, then the risk of having a blood clot will increase. In particular, there are a few risk factors that I think are important to think about. Can you think of any, Jess?
So cancer?
So cancer increases the risk mainly because of this hypercoagulability.
People who are just in bed all the time?
Immobility. And that's the stasis part of this triad.
I think that I heard something about CHF can do it.
So heart failure can cause it, both because of stasis and also with atherosclerosis, there can be some endothelial damage. Some other common things, so sepsis, respiratory failure, these are all important things that contribute to the hypercoagulable state. And oftentimes, if you're in respiratory failure, you're immobilized, so you'll have stasis as well. So some of those are the common things. Other things, having a history of blood clots will increase your risk. Having inflammatory bowel disease or other inflammatory disorders will increase your risk. And anytime there's inflammation, I want you to think of hypercoagulability.
And pregnancy, right?
And pregnancy, of course. So the next thing I think that's important is to try to actually stratify the risk. And there's a tool that we'll use called the PADO score. And you can pull this up on any MedCalc device, any app on your phone. Some EMRs will have it built in. And this will help you stratify whether someone is low risk for a blood clot or high risk. So if you're a low risk patient, we generally would think that your risk of having a blood clot while you're in the hospital is less than 1%. So something that is not important to start on pharmacoprophylaxis or medications to try to reduce that risk. Moderate to high risk patients will have, the estimates vary, but up to 10%. And if you start on a medication to try to reduce that risk, it can go down to 2%. So it's a pretty big reduction in the risk of having a blood clot while you're in the hospital. I think the next thing that's important to do after you calculate this risk is think about the patient's risk of bleeding. So what are some conditions that would put a patient at high risk of bleeding?
They've had a GI bleed before.
Yeah, so gastrointestinal bleed. If they're admitted for a GI bleed, you'd probably not want to start them on DVT prophylaxis.
If they've had, like, been on a ventilator, maybe, or something else that's gonna like break down their stomach lining, if they're on a lot of, I don't know, pressors, things like that, maybe.
Yeah, so certain conditions will put you at risk for having a GI bleed, like being chronically ventilated, having burns, being on pressors. The other big thing I would think about is the other hemorrhage, so intracranial hemorrhage. So having an intracranial hemorrhage or having an active GI bleed would be contraindications to pharmacoprophylaxis. Okay, so now is the most important part, which is the decision tree. So is someone high risk of blood clot? So let's put DVT over here. And this is high and this is low. And then we'll put bleeding risk up here. And this will be high, and this will be low. And so if someone is a low risk of a DVT, in this category, with the general medical patients, we would generally encourage just ambulation or early mobility. So we would say if your risk is low, less than 1%, early ambulation, these will usually be your young, healthy patients, should suffice. The challenging part is when you get into this, if the DVT risk is high, and then you assess the risk of bleeding. So if the DVT risk is high and the risk of bleeding is low, this is the group that we would give medications to. So do you know some of the medications that we'll commonly use to treat or to prevent blood clots?
So heparin and Luminox are the ones we think about a lot.
Yeah, so Luminox. So most commonly we'll use a low molecular weight heparin like enoxaparin. And you would give this once a day. It's 40 milligrams and it's an injection. You mentioned heparin, so who would get heparin instead of enoxaparin?
Maybe if they had renal failure.
Exactly, so renal failure patients. So the one big group that will get sub-Q heparin, which will either be twice a day or 3 times a day, is going to be patients that have a creatinine clearance that's low, so renal failure. So these are your 2 options generally that we use for these patients. And then if the DVT risk is high, but your risk of bleed is also high, like you have an active GI hemorrhage, the other thing that you can do is use some of these non-pharmacologic methods. So things like compression stockings or intermittent pneumatic compression devices. Sometimes we'll call them SCDs, sequential compression devices. And these are basically the squeezers that are on the legs. And the squeezers affect blood clot formation in 2 places. So it decreases the stasis. If someone's immobile and you put a squeezer on the leg, it'll move the blood. But it also affects the hypercoagulability. So there's some evidence that it changes the neurohormonal milieu and actually decreases the risk of having a blood clot. So in this group, if they're at high risk of bleed and high risk of DVT, then you have to make a calculation to determine whether they benefit from pharmacoprophylaxis or whether just to use SCDs. I will say a couple things. So one, if you're going to put someone on enoxaparin or on heparin, there's no reason to also do SCDs because the SCDs can sometimes confuse patients. They can also immobilize them, keep them in the bed, put them at high risk of falls. And a pharmacoprophylactic approach is plenty for patients. If you're going to have someone on early ambulation, if they're not immobile, then you also don't need to do SCDs. So SCDs is really reserved for that one patient group. The one other thing I would comment on is that these are low doses of blood thinners. These aren't treatment doses, so if someone has an active clot, if they're already on a blood thinner for, let's say, atrial fibrillation, then you wouldn't want to continue, or you wouldn't want to stop that medication and start a different one. You would want to continue their home anticoagulant. Finally, the one other thing, sometimes these medications, heparinoids, will put someone at risk for something called heparin-induced thrombocytopenia and thrombosis, HIT. And you'll usually see platelets dropping after that. There's a calculator that you can use. And I would just keep that in the back of your mind if you're seeing platelets drop when someone's on these medications, because that can be a dangerous condition.
So what would I want to use then if that happened?
So there are a couple options. You can use something called fondaparinux, which is a small molecule heparinoid that doesn't cause HIT. Or you could put someone on one of the DOACs, or even if they're high risk of blood clot, put them in the ICU or put them in a monitored setting on an argatroban drip.
What's a DOAC?
It's a direct oral anticoagulant like apixaban, rivaroxaban, or edoxaban.
Okay.
And you'd mentioned if people are on anticoagulants as an outpatient, what if they're on warfarin? Would you keep them on that, or would you have them switch to something different?
So again, if their warfarin dosing is in a acceptable range, which is typically an INR of 2 to 3, we would keep them on that unless there was an upcoming surgery or a high risk of bleed, or if you thought that there was another reason to stop that medication. But you can certainly continue warfarin if they're on it while they're in-house. Finally, would be, who wouldn't you want to put these on in patients? And I would say typically sometimes if they have a severe coagulopathy, so if their PT, PTT are markedly elevated, if their platelet count's less than 50, we'll typically not use these medications, or if they have an active bleed, as we talked about. So those would be the times that I would avoid using these medications.